Me again. Hello. All right, so this is a continuation of our prenatal development chapter. Put myself down here. So we've talked about the three periods of development: germinal, embryonic, and fetal. The need for cell division and duplication, differentiation and implantation, the need for all major organs to develop, and then the need for maturation and strengthening of the fetus in order to prepare to live outside the womb. Now, what we're talking about here is what happens, what can get in the way of any of that happening normally, or the way that would create a healthy infant. Teratology is a science of risk analysis, so it looks at what are the risks that can come, the study of birth defects, what can happen that can get in the way. Teratogens, I always remember it as teratogens to spell it, but teratogens are agents and conditions that can harm the prenatal brain or development and impair the future child's intellectual and emotional functioning. Danger depends on the agent's ability to cross the placenta. So the placenta is there to protect the child or the developing embryo, fetus, and it used to be believed that it was like an armored tank and nothing could get through it. And so it was not susceptible to problems, even what the mother might ingest or whatever might happen to the mom. But we know now that that's not true. And this teratology came out of the recognition that this isn't true. So we have to study what can get through this placenta and what can't. Susceptibility depends on where each organ is in development during exposure. So think about those three stages and where you think the most susceptibility is going to be for any embryo, for any developing child, and definitely going to be inside of that embryonic period when all the major organs and body parts are developing. Things that can cross the placenta at that time, there are going to be potential issues. Most critical during periods of rapid differentiation and cell division of the organ. So when that particular organ is developing. Now we know that germinal period, yes, of course, that can be very susceptible too in terms of just making the cells that are going to make the body. But when the differentiation occurs and it goes to making a lung or a liver, and when that organ is in its development and reproducing cells in order to create itself, that can be very dangerous for that particular organ. Determining risk, as I said, once it was thought it was like an armored tank. Doctors on an Australian military base in the 40s traced an increase in blindness among newborns to rubella, contracted by pregnant women a few months earlier. They realized that some diseases could harm the fetus, and so, this whole science was born out of that, and that there are conditions that can cause problems. So let's look. It's really hard. If you try to find, you can find this all divided up in very many different ways in different places. So this is one way. 4 categories of teratogens. Physical agents that can elevate body temperature, so radiation, we know, and they'll always ask you, well, women, are you pregnant? If you're going to have x-rays or anything like that, they put that big thing over your body. High levels of radiation produce abnormalities of the central nervous system and eyes, 8 to 16 weeks after fertilization. We can't assume that one x-ray is going to cause a problem or anything like this. I always hate to say this, but in some ways, some of this is a crapshoot, quite honestly. Some things, one woman's child will be harmed and another's will not. So what exactly, and this is all still in research and development, basically, and understanding. So 8 to 16 weeks after fertilization, hot tub saunas, infections that raise temp to over 100, anything that can raise the body temperature of the pregnant woman over 102 can cause some problems. Neural tube defects, we talked about that neural tube developing, spontaneous abortions, which are miscarriages, various cardiovascular abnormalities. Early 1990s found an association between high fevers and congenital abnormalities such as cardiac defects, abdominal wall defects. So, we want to stay out of the hot tub, stay out of the saunas, stay healthy, as possible during this time period. Chemical agents, metabolic conditions, malnutrition, diabetes, thyroid conditions, can potentially cause problems with developing fetuses. Hypoglycemia interferes with some proteins in the developing fetal heart. So we want to just make our doctors aware of any of these issues we have. We want to know what we can about our health and make sure we're taking care. Thyroid conditions, abnormal amounts of the thyroid hormones can cause miscarriage, premature separation of the placenta, preterm labor, lower IQ scores in children. Lead, mercury, PCBs. Now this is, recent, this Flint, Michigan issue. To 2016, where we are now, when I'm making this, that in Flint, Michigan, water became lead contaminated in April of 2014 from the Flint River. And lead leached from pipes and fixtures into the drinking water, and over 8,000 children have been exposed at the time that I was researching this. High levels, and so that's the Flint, Michigan thing. So we see this even happening now, even though, things are supposed to be checked for lead and all that kind of stuff. So we have to be aware of these things. High levels of first trimester measures of fetal lead adversely impact neurodevelopment later in life. High levels of first trimestic measures. So within those first 3 months or so, if there's exposure to lead, it can lead to problems in children later in life. Infections like rubella, herpes, syphilis, chickenpox. During the first 20 weeks of pregnancy, 2% chance of congenital varicella syndrome, scars, defects of muscle and bone, malformed and paralyzed limbs, small head size, blindness, seizures, so rarely seen after 20 weeks. But during that first 20 weeks, it's very dangerous. So this is why there can be very critical periods depending on where the child is in development. You don't have to know, I don't expect you to know what every single thing does. I'm just trying to show you the kinds of things that are being studied, that are being researched, and what do they cause. And these are changing all the time with different research. Maternal conditions in the mother, and drugs or chemicals ingested by the mother. This chemical agents is a lot of like metabolic, hormonal, things like the lead, the mercury. But let's see. Obesity, diabetes, these can impact the developing child. Drugs such as alcohol, cocaine, thalidomide, Agent Orange, vitamin A, tetracycline, can have been found to cause potentially problems. Again, not for everyone and not at all times. Fetal alcohol syndrome. Alcohol has been found to be a problem. It wasn't used to, we didn't used to think that it was. And it's one that has sort of a threshold effect, which we'll talk about in a little bit. It used to be like when my mother was pregnant with me, they told parents, oh, have a drink to calm you down, to deal with your stress. Where now we know that the alcohol itself can be damaging if taken too much and at certain times. So there's still doctors that'll say, a glass of wine here or there isn't going to harm anything. But fetal alcohol syndrome, too much at the wrong times, minor facial abnormalities, damage to the brain, learning, behavioral, and cognitive problems. Tetracycline, which is a drug that, it can be common. Antibiotic that easily crosses the placenta. Not all drugs will. This one does. Yellow staining of teeth, diminished growth of bones can cause. Nicotine, smoking, constricts uterine blood vessels, causes decreased uterine blood flow and supply of oxygen and nutrients to the embryo, compromises cell growth, one of the leading causes of low birth weight in babies. So smoking, a definite teratogen. Pot. I have to talk about this one because I think too many people think it's not dangerous. The active ingredient of marijuana, THC, crosses the placenta easily and may persist in the fetus for as long as 30 days. So think about that. The fetus is getting high too, and it can stay there for a long time. Growth retardation and malformations are reported after marijuana use during pregnancy, especially in the first trimester when things are just developing. And, keeping in mind, the brain doesn't finish developing until the mid-20s. And so, any drugs that can change the brain can change the development of the brain. So the effort to understand what triggered such damage gave rise to risk analysis, and we've talked about that. There are some things that are important. Critical period, the time when a particular organ is most susceptible. Talked a little bit about that. So when is that organ in its development, and what exactly has crossed the placenta, and is it dangerous to that particular type of formation? So we see here timing of exposure. So this is the germinal period, these first 2 weeks. You don't really, see a whole lot for problems if we get past that period. In the embryonic stage, we see most, which are considered highly critical, which are the orange. So yes, some orange bleeds over into the fetal, especially the central nervous system, which is going to include our brain. That can be all the way through. And there's some less critical periods, but certainly certain types of problems can happen. Okay, sorry, I had a little dog barky thing. So we see where you just get an idea that the embryonic stage is definitely the most critical period, and then the fetal period. Second important factor is the dose and frequency. So first we have when. When is the exposure? Is it during a critical period? Critical period for what? Now we have how much are we exposed to? Threshold effect says that certain teratogens are relatively harmless in small doses, but harmful once exposure reaches a certain level. So that can be like alcohol, potentially, or, for many things in our environment, maybe. Interaction effect says that a result of a combination of teratogens. So alcohol, marijuana, and cigarettes, nicotine, are more dangerous together than they are individually. None of them are great, but they definitely have an interaction effect. Genetic vulnerability. Several lines of evidence suggest that genes may be crucial. So we might be more predisposed to having a bigger effect from some of these teratogens than others. How well we handle disease can be genetic, how we handle medicines. Dizygotic twins, which are twins, identical twins, exposed to the same teratogens but have only half their genes in common. I got that wrong. Monozygotic or identical. Dizygotic or not. Exposed to same teratogens but have only half their genes in common are born with different abnormalities. Cleft lip, cleft palate, club foot, more common in some families. So we can have a vulnerability to certain things genetically, and that may be why for some mothers it's, the fetus is in danger, and for others it's not. A little bit of that crapshoot part comes from the genetic vulnerability that underlies the exposure and the dosage and everything else. That just says the same thing. So of course prenatal care is going to be the answer. Getting sonograms, but not too often. Getting sonograms so they can watch and maybe detect these problems ahead of time so that remedies, or at least processes, resources can be put in place. And so those are, we've just talked about different risks, potential risks, teratogens, things that can happen and get in the way. The three ideas of when and then how, the two ideas of when and how much. And then that genetic vulnerability, what is the potential effect based on our genetics that might make us more predisposed to problems. So birth happens. So once we've gotten through all of the, 3 periods of time, or whenever baby is ready to come, the fetal brain signals the release of hormones for the birth. Average duration for first babies is 12 hours, gets quicker for later babies. About 31% of all zygotes, remember zygote is that first initial single cell little organism, of all zygotes grow and become newborns. So we know that only 60% become zygote, or become implanted that are conceived. And then we have embryos that are miscarried sometimes too. And so only about 31 that start out actually become newborns. Newborns' first minutes, they begin to breathe as soon as their head emerges. First breath, color can change, eyes open wide, tiny fingers can grab, toes stretch, mucus. So there's a lot of reflexes that happen, things that happen that we're just designed for, which is still pretty amazing. And then they do what's called the APGAR scale, invented by Virginia Apgar in 1952 to quickly summarize the health of newborn children. She was an anesthesiologist wanting to determine the impacts of obstetric anesthesia on babies. And so she looked at these things: baby's color, heart rate, reflexes, muscle tone, respiratory effort, and it was completed twice, at 1 minute and at 5 minutes, and you were kind of could either get a 0, 1, or 2. So you could have 2, 4, 6, 8, 10. You could have a 10, which would be, whoo, yay! Or you could have some number other than that. Desired score was 8 or above. 3 is considered critical. So that is still being used, created in 1952. There's another scale that we don't hear as much about, but I think is very interesting, the Brazelton Neonatal Behavioral Assessment Scale. And this is a quote from the Brazelton Institute. The scale looks at a wide range of behaviors and is suitable for examining newborns and infants up to 2 months old. By the end of the assessment, the examiner has a behavioral portrait of the infant, describing the baby's strengths, adaptive responses, and possible vulnerabilities. By the end of the exam, the examiner has developed a vibrant portrait of the newborn, which can be used to tailor caregiving of the baby's specific physical needs and behavioral style. Does the baby like to be handled? Is the baby receptive to social interaction? Does the baby easily calm herself? So I think what's interesting about this is not given to all babies that I know of, maybe some places. This gives us not just, and it will look at reflexes and all those kinds of things too, but it also, this behavioral piece gives us a portrait of our newborn that can help us make a good fit. A lot of times when we're getting ready to have a baby, we have this idea that we have sort of this theory of what it's going to be like. We're going to put on our little jumper and we're going to go out into the world and we're going to, skip through the meadows, and it's going to be beautiful and lovely and everything's going to be perfect. And then we get a baby who cries incessantly. And what can happen is we can think, oh my gosh, I'm a terrible mother or father, or it's me, or there's something wrong with the baby. And it can actually cause to distancing, or it can cause to things within parents, their thinking, or whatever. Sometimes the theory, we don't know what child we're going to get when we get pregnant. We don't know who they are and how those genes have interacted to wire them in a very particular way. And so what this tends to do is look at some of that temperament quality, the individual wiring of this baby and how it comes out in terms of resilience and what we could even call optimism levels, how it deals with sensory, with the environment. And then we can tailor our parenting to fit what might be best for our child and create a good fit. Rather than understanding that baby is not going to just fit into a mold that we want, but that we have to discover who this child is and tailor our parenting sometimes for that care. For the baby, and sometimes babies can be born more or less resilient, and down the road I think we'll talk a little bit more about that. But and what that can look like is how easily can they calm themselves. Well, if they have a particular style within the first 2 months, a lot of that has to do with their wiring. If they tend, to have more sort of positive ways of being in the world, or we look at temperament as it's kind of been defined as easy, difficult, hard to categorize, or slow to warm up. And understanding some of that just is innate in our children, and how do we approach that? So this scale is interesting in terms of what it can offer us in that regard. Okay. So C-sections in 2013, there were 2,642,892 vaginal and 1,284,339 C-sections. Percent of all deliveries, 32%. So that's definitely going up, and it goes up more in wealthier countries, of course, because it's definitely more expensive to have C-sections. As a surgical birth, fetuses are removed rates and reasons for C-sections vary. Lower rates in poorer countries, 1/3. Less trauma for the newborn, but slower recovery for the mother because it is a surgery in which, the whole sort of gut's been opened in some ways. I mean, we've been cut. Subsequent cesarean deliveries may be necessary. So there's less trauma. But the interesting thing is, children receive immunities as they go through the vaginal canal, and so they don't receive those necessarily. And that doesn't mean there are some C-sections that are absolutely medically necessary, but what we're finding in our culture is that they're more convenient, and so they are oftentimes done for convenience factor for both the doctor and or the parents. And medical reasons are great, and it's certainly a personal choice, but it's also good to be informed about pros and cons. Sometimes breastfeeding is more difficult for mothers of C-sections. Some of that may be due to the slower recovery and the drugs in the system and so forth. But it can happen. But it might need more help afterwards from a lactate consultant and so forth. So it's just good to be prepared and informed when we make those choices, if we're making them for convenience reasons or personal preference reasons. Low birth weight, the average birth weight is 7.5. Low birth weight is considered less than 5.5. We have very low birth weight, extremely low birth weight. Cigarette smoking accounts for 25% of low birth weight babies worldwide. So that's one thing to be aware of. Maternal malnutrition, multiple births, of course, twins, triplets, quadruplets. There's only so many resources, so that can affect prescription drugs, and there's some unknown causes. Younger mothers tend to have lower birth weight babies. That can be a malnutrition issue, just a not having the prenatal care sometimes. That can happen. So this little newborn, the first movements are not skills. There's nothing that's known. They're just reflexes, involuntary responses to stimuli. Some of those reflexes or those first reflexes are survival, breathing, shivering, thrashing, sucking, rooting. Now, sometimes students don't know what rooting is. If you kind of just do this to a baby, it'll kind of it'll move its mouth that way. It's rooting for the breast or for food. It's not the same as sucking and eating. It's that tendency to just look for when something kind of comes across the face. Swallowing, spitting up, we kind of need all of these in order to survive. They help with survival. These are other reflexes that we find in newborns. Babinski, when the feet are stroked, little toes go whoosh. Newborns, they'll actually lose this one, but if you held upright, their feet touching a flat surface, they kind of move as if they're walking. The swimmy reflex, they kind of stretch out and look like they're swimming. My baby has the strongest grip. The Moro, it's a startle reflex. It's kind of like this, right? Infants fling their arms outward, bring them together. To kind of protect. It's kind of a protective mechanism, but it's a reflex. It's not thought about, not a coping mechanism at this point. It's just within us to help us. Social support, I just like to, point this out. It's very important. It's whether or not parents are together, it's very valuable to have a parental alliance, for there to be a cooperation. If you're bringing a child into this world, to both take that obligation seriously and work together for the betterment of the child. Postpartum depression in 8 to 15% of women. This can be upon a continuum of kind of baby blues, just not being, being a little depressed. Or just a little, not feeling like you thought you were going to feel when the baby was born, to actually a psychosis of sorts that can happen. It happens a lot it can happen to mothers so much. Mothers' lives change a great deal, and their hormones change, and their bodies change, and much is shifting. And so whatever support, and a lot of that causes stress and the worry, and all the things that are kind of on you to get right for this, and that feeling at least. And so having support is so incredibly valuable and important, to find people and that will support you and positively support you in this journey. Supportive fathering helps the mother stay healthy. Study shows a correlation between absent father and medical complications during delivery. So it's always helpful to have that parental alliance, to cooperate, to be there and take this obligation seriously. that parent-infant bond. We're going to talk a lot about this when we get to 7. There are things within us that create this, but it's also good to understand too that it can take time. I think it can be dangerous to feel that if I don't feel this immediately, that there's something wrong and I can't. A mother, has gone through quite a bit, and it can take a little bit of time for the hormones to settle, or even the drug, or just the exhaustion. And for fathers who haven't carried the baby, there can be feelings of just disconnect. So often there is that first bonding, but it happens, in time and with care, no matter what. Kangaroo care, especially for little ones. This is an actual strapping of the baby like a papoose. A lot of times the first 3 months of pregnancy can be called kind of the 4th trimester, even though tri means 3, in which, attempting to recreate that sense of womminess for a child. Just think about newborns. They have come from a very safe, sort of watery, dark, comfortable, warm world out into a bright, loud, crazy space. And to kind of try to recreate that, to slowly bring a baby into this world, to understand that that's not always easy for all babies. Now, some may have an easier time of it than others, and that can be that good fit too. Is my baby hypersensitive to all of the stimuli? Do they need more of that touch and that hold? What do they need in order to grow and to develop? Getting to know them and their specific temperament is helpful, because it's not all easy. It's not all running through. My child, I put him in the little papoose, gonna go, he just threw up everywhere. He didn't like it. And I had such dreams and theories about that. So we have to understand that we're going to have that, and then we have to let go of it, or we have to deal with when those expectations are different. It's beautiful and glorious, and it's also hard and challenging. And it grows us and builds us in ways that we can never even comprehend. And it's a love that can be unfathomable and a frustration that can be unfathomable. It is both and, not either or. And I think that's important to remember. So here is another one, a video. Oh, and I didn't put it on here. But I intend to watch this in class from my ground. My online watch it. I think it's great to think. Ask yourself, when does learning begin? And then see what the answer is here. So thank you for joining me through the prenatal chapter, and I'll see you soon.